Since the time given is too short, let me show you only the cases rather than having a detailed discussion on left main dissection management. Let us run through some of these slides. Well, despite all the pre and peri-procedural precautions, mishaps do occur. And this is one of those mishaps, complications of left main intervention. And dissection is the most lethal and serious complication. Rare, incidence is low, and the course is very unpredictable depending upon how bad is the dissection. Causes are too many. Let me forget about these things right now. Now, we classify these dissections into two types, antegrade and retrograde. There are several classifications, but I think what is most important is a simplified classification of LMC dissections. Type 1 is when it is localized dissection without extension into LAD and LCX. Type 2 is when LMCA dissection extends into LAD or LCX, and type 3 is dissection extending into the root of the aorta. Let me go on to the cases first of all. This is the case number 1. This is a patient who had a left main trifurcation stenting. This is the pre-PCI left coronary angiogram. You can see here LAD, the two branches coming in between the circumflex and the LAD. One is possibly a ramus, the other is a obtuse marginal branch. And we did a SKS technique and jailed the guide wire of one of these branches. SKS technique was done successfully. And then we rewired this obtuse marginal branch through the struts of the LCX stent and stented the obtuse marginal branch. Now, following that, we did a triple balloon kissing using two guiding catheters from both the groins, and we thought the job has been done. But then when we looked at the result, there is a major dissection in the left main, possibly caused by triple balloon. You can see on the superior border. So this had to be confirmed by a IVUS done. So IVUS shows that the stent is well opposed, and there is a horseshoe-shaped dissection in the body of the left main, which was extending right up to the ostium of the left main. So obviously this needed to be sealed. So we deployed a DES in LMCA, a very short DES. I think it was 8 or 9 millimeter into the left main, going into one of these struts, which was in the SKS technique. Having done that, this IVUS was repeated, and you see that the dissection has been totally sealed. So this is the final result. Excellent result. Okay. Now, this is a very frightening case. This is a dissection which is extending into both the LAD and LCX branches. This is a totally normal left main, but we are doing a circumflex artery, which was subtotal occlusion. So I was very fond of using Amplas guiding in these cases. So we use Amplas, and I guess right from the beginning that we are heading into a problem. So you can see the tip of the guiding is lying right at the mouth of the left circumflex artery. And this was used obviously to get a support from the circumflex, from the guiding to go into the circumflex and get access to the distal part of circumflex through the CTO. So once we had crossed this, the guide wire is in the PDA, and we did a balloon dilatation at the CTO site. We pulled the guiding out, and this is what we saw. There is a major dissection in the left main, and this is extending into the wall of the aorta with the dye leaking into the wall of the aorta. The patient became symptomatic at this point of time with severe chest pain, but there was no fall in blood pressure. Now, the point of interest here is I must pause for a second and tell you that never ever pull out the wire and the guiding catheter in a hush in this state. Because if you pull out the guiding catheter and the wire, then you would lose an access to this, and then you may catch a false lumen with another guiding catheter. So what we did was we withdrew this guiding catheter a little bit, and how we withdraw the guiding of a Amplas is that you push it a little bit. So it comes out of the left main, and then we partially withdrew this guiding catheter from the LMC, as you can see here, and then we took another wire, and we passed this wire, which took us a minute or two to get into the true lumen, and we had a wire already in the circumflex. So with this we wired the LAD, and then we did a left main bifurcation stenting. You can see here that we first stented the circumflex at the CTO site, and then put a long stent in going from the left main into the LAD, sealing the dissection. And this was the result after the bifurcation stenting. There is some small leak which is still there, but next day we got the CT angio done, and this was all sealed. So this is just the final kissing balloon dilatation and the angiogram final result. And then, of course, we completed some of the other distal vessels. Now, the last and the most lethal dissection. This is a old lady about 78 years of age. She came with acute inferior wall MI, and we did her primary angioplasty, and so she was doing well. On day 3, she had some disease in the distal part of the LAD, which is not seen here in the bend, some in the hair. So I don't know why we thought we should treat all these vessels. So as soon as we hooked the left main with the guiding catheter, and you can see here, the guiding tip hit the left main, and it caused a serious dissection which extended on to the circumflex. Well, we had not even wired at that time. So with a lot of difficulty we could wire this circumflex, and we wanted to now implant a DES into the osteoproximal part of the circumflex. But the stent would not go. With a lot of difficulty we could manipulate the stent. Finally the stent got into the LCX, and we kept the proximal end of the stent right at the ostium of the circumflex. The stent was deployed, but somehow the stent did not open up completely. It did open up, but it did not possibly relieve the obstruction completely. So now we were trying to pass in a balloon to open up the stent further on, and passing the balloon led to hitting of this balloon, distal end of the balloon into the carina, and that led to the dissection extending from the circumflex ostium into the LAD, and the whole LAD started occluding. So we had to wire with this LAD with a lot of difficulty. By this time the patient became hypotensive. I'll skip this step. So once the LAD access was obtained, so we put multiple stents into the LAD and sealed the dissection. Finally, we put a long stent from LAD backward into the left main, and this was the final result. So everything became all right. Patient became normotensive. So the take-home message is that rapid action response is the key to success in these patients. Careful manipulation of catheter, balloons, stents, and other devices is extremely useful in preventing mishaps and mortality due to left main dissections. Thank you.